So developmental abnormalities. The primary vitreous is involved in the embryology and the embryologic development of the eye. Do you guys still do ocular embryology as part of the board series? Yeah. So the vitreous is derived from the neuroectoderm of the optic cup, and it has to do with the cascade of programmed retinal vascularization. It helps develop the vascularity of the retina, the retinal capillary lines, the retinal vasculature, not the choroidal vasculature, but the retinal vasculature is intimately related to the embryology of the vitreous. The vitreous is opaque in early fetal development. You cannot see through the vitreous in very young preemies, for example. Do you guys do any ROP exams with Dr. Nakanishi, perhaps?
30 years.
30 years.
We see young babies and we do see. Yeah.
So when you look at very young babies, their vitreous is hazy because it is not yet optically clear. It does not become optically clear until they're about 33 to 35 weeks of adjusted gestational age. And that has to do with the embryology of the vitreous and the vascularity of it and the tunica vasculosa lentis. So at about 1 month of gestation, the hyaloid artery branches to form capillaries on the posterior surface of the lens capsule. These move towards the equator of the lens and they anastomose with the anterior pupillary membrane, which has to do with the embryology of the pupil, at about 9 weeks estimated gestational age. The tunica vasculosa lentis then disappears through programmed cell death shortly before birth, usually about 36 or 37 weeks of estimated gestational age, but it's present in preterm infants. We see it in ROP babies all the time, and that's one of the reasons that you have trouble lasering, or used to have trouble lasering patients with aggressive posterior, what's now called aggressive posterior ROP, because they would develop bad ROP very posteriorly in the eye while they still had a tunica vasculosa lentis, and then you'd have to try to laser through this vasculature, which would pick up the laser. That's been ameliorated by using anti-angiogenics in some of these younger patients with bad ROP, but fortunately most ROP, like ROP that goes to threshold, occurs around 35, 36 weeks of adjusted gestational age, and the tunica vasculosa lentis has regressed by then. You can get in a good laser pattern in older preemies who develop ROP. Now ROPs very gratifying. If any of you have an interest in ROP, you can always come with me or Dr. Hess here at All Children's. We look at ROP babies every week. Just let us know. We're happy to tote you along. Plus, if you ever feel like you're having a bad day, you can just take a social history in the NICU and you'll feel like your bad day is a trip to Hawaii. Poor folks have a really tough time, which is why they have premature babies. Okay, here's the tunica vasculosa lentis, the anterior pupillary membrane, the hyaloid artery, how the embryology of the eye looks when it is at its most vascular, and you're developing the pupil, you're developing the retinal vasculature, you're developing the lens. Do you guys know what structure the hyaloid artery becomes in the vitreous once it regresses? It's another eponymous structure. Yeah, Cloquet's canal. That is correct. And this is what tunica vasculosa lentis looks like in a premature baby. That's why it's tough to get laser through that if you were going to laser a very young preemie with aggressive posterior ROP. So persistent fetal vasculature has to do with the embryology of the vitreous as well. This results from failure of the vascular complex to completely regress. You get an associated retrolental membrane, cataract, microphthalmos. You can have disorganization of the anterior segment, retinal detachment, but like everything else that we see, there's a range of severity. Sometimes you'll see an adult who has very mild persistent fetal vasculature and a mildly amblyopic eye maybe, and you look in the eye and you see this stalk and a posterior subcapsular cataract, and that is mild persistent fetal vasculature. It used to be called persistent hyperplastic primary vitreous. That term has exited from your board review books. Is now called persistent fetal vasculature. What's important from a board review standpoint is that this is uncommon and sporadic. This is not heritable, and it's almost always uniocular. It's almost always in one eye. You don't see bilateral persistent fetal vasculature in most cases. Observation, cataract surgery, or vitrectomy are all reasonable things to consider depending on the spectrum of findings and the severity of the persistent fetal vasculature. This is a photo from a retina gallery. It was very hard to find these patients and photograph them of, I'd say, probably mild to moderate persistent fetal vasculature. You see persistence of a fibrous stalk where the hyaloid artery was, right where Cloquet's canal should be. All right. So, hereditary hyaloidoretinopathies with optically empty vitreous. Have you guys seen any of these patients in real life? No, these are pretty rare. I can't count on one hand how many of these patients I've seen in real life. This is a group of anomalies called Stickler's syndrome. There are 5 types of it, which I don't think are important for you to know for the purposes of general ophthalmic education and board review. What is important to know is that it's a problem with type 4 collagen production. Most cases are autosomal dominant, so it's passed down in a dominant form, and it's a spectrum of problems. It's not isolated to the eye. You wind up with craniofacial abnormalities, hearing loss, distinctive features. Kids who look like this, kind of with Stickler syndrome, they wind up myopic. They wind up with basically liquid appearing vitreous, and they wind up with a high incidence of retinal detachment. It's a clinical diagnosis based on how many points of Stickler's abnormalities you have. And if you have 5 points of abnormality, you're called a Stickler syndrome patient. You can also get genetic testing these days for it. So Stickler syndrome is dominantly inherited, type 4 collagen, all kinds of craniofacial abnormalities, retinal detachment with optically empty vitreous. Familial exudative vitreoretinopathy. This is another genetic abnormality. It's familial because this is heritable. Just like Stickler's, this is heritable, and it's a problem that is related to signaling, which is called WNT signaling, that affects the growth and development of retinal blood vessels. It's dominantly inherited like Stickler syndrome, and it also has a range or a spectrum of severity, from asymptomatic with amblyopia to vitreous hemorrhage, tractional retinal detachments, neovascularization, and you treat it like other proliferative retinopathies, like retinopathy of prematurity or proliferative diabetic retinopathy. You treat it with laser photoablation. You probably can treat it with anti-angiogenic therapy, and it's staged kind of like ROP in stage 1 through 5. Also, that's not prescient for your knowledge with regards to the boards. What is important is that it's dominantly inherited. It behaves like ROP or proliferative diabetic retinopathy, and you laser it if you see it with problems. These are 2 examples of familial exudative vitreoretinopathy with problems. The patient on your screen left has a tractional fibrotic neovascular membrane, and the patient on the right is an ultra-wide field angiogram where you have ischemia anteriorly on the right side of the photo on the right with neovascular fronds, and that's probably treatable with laser therapy or possibly cryotherapy if you can't get all the way out there. I've actually not seen a case of familial exudative vitreoretinopathy outside of fellowship. Have you seen one?
No.
Pretty rare.
Yeah.
Pretty rare. Maybe we should get an Optos and try to find them. These are pretty rare. They're pretty, but they are dominantly inherited. Familial.
Yeah. Yeah, there's sometimes you'll look at an eye and there's something over there.
Yeah, you wonder if it is, but it's not active.
But that's the most I've ever had.
Yeah.
I think Scott had one. Okay.
How was your patient treated in Miami? Laser?
Laser, yeah.
Looks good?
Yeah.
Yeah, it would probably look good with laser. So vitreous opacities. These are our most successful vitreous surgery. And you can kind of maybe couch that by saying it's not a very bad problem, so it's not a very bad surgery maybe. The question is, do you even do surgery for vitreous opacity? Some people won't. A lot of retina specialists will in the modern era. But vitreous opacities are a very common complaint, especially after posterior vitreous separation. We spend a lot of time talking people out of intervention for vitreous opacity because vitreous opacity and floaters, especially after posterior vitreous separation, often get better. They often improve spontaneously. But a couple of pearls, in addition to the fact that most resolve, are that these are very happy patients after vitrectomy, if you do elect to do vitrectomy on patients with vitreous opacity. And pearl number 3 is there's a new wave of disruptive vitreolysis using YAG lasers with a new confocal laser and a new mid-vitreous lens that has actually been demonstrated to be safe and effective in a small randomized controlled trial run by Chirag Shah, ophthalmic consultants of Boston, but which is still not really a widely adopted procedure. Should it be? I don't know. I think we have to accumulate some more evidence and find out. But certainly the technology for disruptive vitreolysis is changing. I do offer, and other of my practice partners do offer vitrectomy for vitreous opacity, and these patients are very, very happy. This is probably our single most successful retinal surgery or vitreous surgery. It's not a retinal surgery. It's our most successful vitreous surgery when we elect to do it. Another story, a very famous retinal mentor of mine said the easy part is doing the surgery, and he's pretty much right. 10 years into doing vitreoretinal surgery, the easy part is doing most surgeries, not all of them, but most of them. The hard part, and this is still the hard part, is deciding which patients to do surgery on. That's always going to be less than straightforward. This is a good example of a condition where the surgery is technically reasonably straightforward, but selecting the patients can be difficult for a whole lot of reasons.
How long do you typically wait before you offer the surgery? Or
It's a good question. I like to wait after a PVD for posterior vitreous detachment associated vitreous opacity. I like to wait at least 6 months after the PVD. Have I done it sooner than that? I can count on one hand how many times I've done it sooner than that. A lot of guys who are aggressive with this will do it immediately after posterior vitreous separation, which is probably not reasonable. But making them wait 2 years when they are really unhappy is probably not reasonable either with modern vitreoretinal techniques and the safety profile we have with small gauge vitrectomy. I like to wait 6 months. I like to document that I've talked about it at least once or twice before offering them surgery. Is that what you do too?
Yeah,
pretty much.
Yeah.
Have you had any problems with tears?
Yeah. So Herschel asks a very prescient question. Have you had any problems with tears? So the risks after vitrectomy for vitreous opacity, of course, include death by anesthesia, loss of the eye, infection, bleeding, scarring, all of which are very rare and hardly ever happen. But what can happen is retinal tear and detachment with an incidence in the best series we have of 1 to 2%, which is a greater incidence of a complication than any of those other more serious problems. So I have had retinal tear or detachment after vitrectomy for vitreous separation, and that's why you don't just rush everyone off for it, because there is that 1 to 2% incidence of retinal tear and detachment. And that's why, if disruptive vitreolysis is shown to be safe and effective with these new technologies for focal vitreous opacities, it might be reasonable from a vitreous surgery perspective. And disruptive vitreolysis will not work for someone who has like a sheet of opacities, and these are opacities that are characterized by Dr. Shah and others who have done work with disruptive vitreolysis, but focal opacities like Weiss rings may be reasonable to disrupt as we develop experience and evidence with these newer vitreolysis technologies. So a typical floater case, 71-year-old female, pseudophakic, comes in. Of course, this is a vitrectomy, so if they're phakic, they will have to become a pseudophakic if they want to see well after vitrectomy. So most floater vitrectomies probably are pseudophakic, at least in my hands, are pseudophakic to start out with. Pseudophakic, they come in, they're very annoyed by a central floater vision. It's 20/25. You gotta remember in your floater cases, you're taking an eye that's 20/20 or 20/25 or 20/16 to the operating room for a vitreous opacity, which is why if you get that 1 to 2% incidence of retinal detachment, which winds up, at 20/100, things are not good. Here's the patient, 20/25, vitreous opacity, beautifully photographed, a color photo, and there it is, right there. It's that lesion that's obscuring the vessels in the bottom part of the picture going up towards the optic nerve. And there's the opacity. This patient did not get vitrectomy for this vitreous opacity. Asteroid hyalosis, calcium soaps in the vitreous. They are often associated with strong vitreoretinal adhesions. And the interesting thing about asteroid hyalosis, if you're trying to differentiate it from other entities we'll talk about, like amyloidosis or cholesterolosis, is that asteroid hyalosis is less symptomatic than the appearance would suggest. That's characteristic of asteroid. It's bilateral but asymmetric, and it worsens over time. So asteroid, minimally symptomatic, bilateral, worsens over time. Here's a case example, 80-year-old female who's pseudophakic, and this patient had a hard time reading due to floaters. There are her floaters. She is symptomatic from these. She's an unusual asteroid patient that she is symptomatic. And after vitrectomy, she looks like that. Nice and clear. You can now see her macular degeneration and equatorial drusen, which are not bothering her because she has her floaters out. Vitreous hemorrhage. This is the classical vitreous opacity associated with many pathological conditions. We talked about it today. That's why I brought that case in today in the context of this lecture. They often clear over time, but this is a reasonable and classical indication for vitrectomy. A pearl is the first vitrectomy performed by most historical accounts was Robert Mockemer's vitrectomy for vitreous hemorrhage on April 20th, 1970. He had an instrument called the VISC, which was the Vitreous Infusion Suction Cutter. It sucks and cuts, like in Wayne's World. And he performed vitrectomy for vitreous hemorrhage on April 20th, 1970. So the field of vitreoretinal surgery is actually a very young field. It's only, as far as vitreoretinal surgery with vitrectomy goes, the field is only 47 years old. So it's very young compared to most other surgical fields. Retina is especially as older. There was buckling prior to vitrectomy, which was the surgery that was popularized right around World War II by Charles Scapins in the United States. But vitrectomy is newer than that. It's from the 1970s. All right. And the first commercial vitrector was the Occutome, which wasn't sold until 1972. So it was, it really is a young field. Here's a vitreous hemorrhage. It's a good example of one that might need vitrectomy. It's a diabetic. Cholesterolosis or synchronous scintillons. I don't think I've ever made this diagnosis, but this is an accumulation of cholesterol crystals in the vitreous. It's rarely seen in humans. I looked this up, to try to find a picture of it since we don't have one. It's common in dogs and in the veterinary literature because no one does anything for their pets. That's expensive, it turns out. So the dogs have terrible chronic eye conditions and they all develop cholesterolosis because their conditions are untreated. It involves chronic eye disease involving hemorrhage. It looks like this. This is an example of a patient who is aphakic from trauma with a chronic retinal detachment and vitreous hemorrhage that I found online. There's cholesterolosis in the vitreous, and there's a crystalline hypopion from the cholesterolosis. This eye was blind and painful, and this is the picture prior to enucleation. Vitreous amyloidosis. So the thing that the board might have you differentiate is asteroid hyalosis, cholesterolosis, and amyloidosis. Amyloidosis is also very rare. I have not seen a case of vitreous amyloidosis, but it's part of the disease amyloidosis, which is a heterogeneous group of disorders characterized by deposition of hyaline extracellular material. It's a pathologic diagnosis. Do you guys know what structures other than the vitreous it affects that are most commonly biopsied in ophthalmology to make the diagnosis of ocular amyloidosis? Conj, right. Conjunctiva. It affects your extraocular muscles. It affects your eyelids. It's found pretty much everywhere. It sounds really unpleasant to be an ocular amyloidosis patient. And you can get vitreous amyloidosis. This has a classical description as initially granular with wispy fringes, and I miss these classical descriptions, It's like serpiginous used to be called helicoid maculopathy. That's a great description. And serpiginous, like a snake, helicoid, like a spiral, granular with wispy fringes. I feel like the OCT, I feel like an old man right now saying this, but I feel like the OCT is making our descriptions much less fun sounding. But initially granular with wispy fringes is the classical definition for vitreous amyloidosis. What makes it different from asteroid is that it's often symptomatic, is what the literature says regarding vitreous amyloidosis. It's bilateral and it's symptomatic, but it looks kind of like asteroid hyalosis, best as I can tell. This is granular with wispy fringes as opposed to asteroid, which is which is calcium soaps. And finally, the very last vitreous opacity we're going to address is vitreous abnormalities secondary to surgery. What do retinal surgeons do to put in a vitreous opacity? What are you going to do, Herschel, during that first case for a macular pucker where you make one of those huge iatrogenic holes? What are you going to put in that eye at the end of the case?
Oil.
Oil. You put in oil, which is iatrogenic vitreous abnormality, which we use and is very, very helpful in many, many cases, but it is a problem if you have complications of oil retention. This is a good example of problems related to oil retention, which usually involve the anterior segment. You can get oil into the anterior chamber, like in the photo on the left, through an aphakic or pseudophakic pupil. And on the right, you have chronic oil with an inverse hypopion from emulsified silicone oil floating up to the top of the anterior chamber. So we can cause vitreous opacities with much less frequently than we treat or cure vitreous opacities in the field of vitreoretinal surgery. But that's pretty much it. That is the end of my talk. That is the world of vitreous opacity, vitreous abnormality, congenital vitreous problems, and vitreoretinal adhesion disorders. Any questions or concerns or things you'd like to talk about?
Actually, remember that we had asked about the
Yeah.
LPI and how it was.
That's why you do an inferior PI in this case, because the oil would block the superior one. It
So
wouldn't be
the-
effective. Is that right?
Well, you do an inferior PI to relieve pupillary block because the oil goes up, and you can get pupillary block glaucoma if you have an aphakic eye, for example, which is the easiest example, or an ACIOL eye, and you have a good oil fill. This is a good oil fill probably, but it may be a little too much because of the picture on the left. It's in the anterior chamber. So this is a good oil fill, and it's right at the pupillary margin. If it blocks the pupillary margin and it blocks that superior PI, this can happen with gas too, but with gas it's transient. With oil it's possibly not. You wind up getting high pressure because you cannot have circulation of the aqueous from the ciliary body to the front part of the eye. You get iris bombée and closure of your angle. But if you have an inferior PI and the oil floats up a little bit, because you never get 100% oil fill, you get like 95% if you're really good. The oil floats up a little bit and you get the aqueous flowing anterior to the oil, posterior to the pupil, through that inferior PI and flattening your pupil in the perfect world with a perfect oil fill. You'll find when you're a retinal fellow, it's not as easy as it sounds to get a perfect oil fill.
What's the other 5%?
The other 5% is aqueous, because
In the posterior segment?
aqueous in the posterior segment, yeah, that's right. You get, ideally you get